Okay. కెమెరా ఓపెన్ కావట్లేదు మా ఒక్క సెకండ్ ఆగొచ్చు కదా.
Adi, Harish, we are live now.
People are still joining right now.
Good morning, everyone. We'll wait for a few more minutes, then we'll start the session. Harish, is the technical issue resolved?
No, Madhuri, I'm just trying. Just give me 2 minutes.
Okay. Meanwhile, I hope everyone you had your coffee and you are ready for an engaging session today. I truly appreciate you taking the time to be here, and your presence means a lot. We value your time, guys. Give us 2 minutes. We are facing some technical issue. We will start the session once it is resolved.
Good morning, all of you. Happy Saturday and welcome to another exciting learning session. I still see some people joining in, and I think we should give a minute time for everybody so that we take advantage of everybody going through the session today. All right?
Yes.
Great.
We are receiving a lot of messages, Adi.
Oh,
All are ready for this exciting session.
wow, that's nice.
Yeah.
That's amazing, guys. And the way that you come with an enthusiasm to learn things, the way that we are here to make you feel or meet your expectations on learning. And thank you for taking this time and getting on for another exciting learning session. Harish, are you ready?
Our speaker is facing some technical issues, Adi. So
Okay.
I request everyone to be on hold. Just give us few minutes. He's trying to log in again.
All righty.
Yeah.
Adi, can you hear me?
Yes, we can hear you, Harish.
Harish, are you
I
ready,
have an
Harish?
issue with camera.
It's okay.
So,
That's fine without the camera, Harish. I think you should be able to present the screen. That should be good.
Okay. So, guys, let's make this session both insightful and interactive through your active participation. I'm confident that we'll have a meaningful discussion and a productive learning experience together. Without further delay,
Absolutely.
it is my
Absolutely, Madhu.
yeah. So, without further delay, it is my pleasure to invite our chapter president, Mr. Adi Lakshmi Garu, to introduce our esteemed speaker. Adi, over to you, Adi.
Thank you. Thank you, Madhuri. Good morning, everyone, and happy Saturday, all of you. I know everybody are excited the moment when we see the topic as CDI. We've been hearing about the CDI from over a period of time. But I think we have our chapter treasurer, chapter officer, Mr. Harish Chunduri, who comes with a great experience in training, learning CDI, and also a CDIP certified. So I welcome Harish for another knowledgeable, exciting session from you. And I hope everybody start making the notes. Reach out to us for any other extended session from Harish. We would be glad to walk you through on it. But today, this 2 hours is going to be a power-packed session today on the CDI. All right. Welcome everybody to our Hyderabad local chapter for today. And welcome Harish. And the platform is all yours. Looking forward to hear you on the CDI. Over to you, Harish.
thank you. Thank you. Thank you so much, Adi. Thanks for the introduction. Guys, please excuse me. So I have some technical issues in in my camera. I don't know, I could not show you guys my face, but I'm trying to resolve meanwhile. But anyways, we'll start a session. So as Adi mentioned, so we'll be getting into this topic called CDI beyond coding. So demystifying impact in inpatient and outpatient. So, but before that, so Adi, just wanted to check, am I audible?
Yes, Harish, you are audible and the screen is visible. Yeah.
Okay, good. Thanks again, Adi, so for introducing me to the group. So guys, so today we'll be discussing about this CDI beyond coding, so demystifying impact in outpatient and inpatient care. So this presentation, so this basically helps us to understand, since we majority of us are here as a coders, so very little, or there is a very little development about what CDI does or about CDI in current Indian market. However, so we would go about basics of what CDI is. Okay, so what are the CDI principles? Why CDI is important? What is it relation with coding? And what is the scope? Like what CDI specialists do versus what coders usually do. So what is the importance of documentation? Okay, so what are the major principles around working into a CDI world? Uh, so what impacts it creates both in inpatient and an outpatient settings? So these are the major things that we would be discussing today. Um, So let's get into this presentation. So this is a standard disclaimer. So these are the agenda that I'm talking about. So we will discuss about what CDI is and its scope. What are the basic differences and their impact on CDI versus coding? And the very, very important area that we would be touch basing in this presentation is about the value-based care era, value-based care era introduction, and why CDI matters today. What are some query basics, some CDI workflows in inpatient and outpatient settings, some practical examples, and some optimal metrics for a successful CDI program. I hope this session provides you a basic insight about how a CDI role or a CDI functions in the healthcare. And as Adi mentioned, try to jot down your notes. So at the end of this session, we'll also have a Q&A session where any questions that you have around this area, we can get deep and we'll try to answer your questions. So without making any further delay, so let's get into our presentation. So first thing, so before I start, just wanted to put a question across to the group. So what do you think is the most important factor for a successful code capture? Is it accurate physician documentation? Is it clear coding guidelines, the technology, or the knowledgeable and qualified coders? Let's take a minute. I want you guys to put your responses in the chat box. So meanwhile, Madhuri, if you can just monitor this, and let me know what are the
Harish.
major responses that we
We
are
are
getting. So that will be
receiving
helpful.
mixed responses here. Few are responding it as A, few are responding it as D. So majority of the group, it is responding as A, Harish. So they are voting for accurate physician documentation.
Great. Shall we give few more seconds or?
We received enough responses, Harish. Majority of the group responded here.
Okay, great. Fine.
Yes.
So as majority of the people have responded A, so the thing is, we need all of these, but yes, I would also incline towards majority of the group's decision. While the accurate physician documentation takes the first place in the 4 options that we have, but at the same time, we would also require the other 3. Okay. So we would require, of course, the major part, which is physician documentation. We would also require some clear coding guidelines. So without following coding guidelines, we will end up coding. We will end up in a wrong place. Technology, yes. So we would require. So in our present world, to make our life better, obviously, majority of us are dependent on technology. Like we need EHR, we need AIs, we need CACs for us to. So maybe they'll not replace our work, but at least they'll assist what we are doing. How we can do better. So the next one is knowledgeable and qualified coders. Of course, this is also one of the major criteria. But yes, according to what group is saying, so A takes precedence over the other, but however, all the 4 are important. Good. Thanks, guys, for answering. So now let's get into what CDI is. Okay, so what the principles is. So the standard, so in a standard way, okay, CDI is defined as a process that reviews and refines patient medical records to ensure the documentation is complete, specific, and accurate. So CDI aims to capture all relevant diagnosis, treatments, and patient complexity to support correct coding and quality data. Remember one thing, so the CDI is not all about getting a reimbursement or getting a higher reimbursement, which is the common myth that we have. However, so the main goal for a CDI process is to have medical documentation to be complete, specific, and accurate. So with this step, so there are many advantages that it brings in. Yes, first, it removes that reimbursement flaws, but at the same time, it also provides quality outcomes. It also gives a clear clinical picture about what's happening with the patient. Okay, so this is a standard definition that we have. So years on years, so the definition has been evolved, and the CDI usage cases has also been evolved in the healthcare space, especially the US healthcare space. So there is no much difference, but however, this is more elaborated definition of CDI. So it is a multidisciplinary, patient-centered practice that ensures that the health record accurately reflects the true clinical picture of the patient's care and outcomes. So modern CDI extends beyond its traditional focus on reimbursement and coding to encompass quality reporting, risk adjustment, patient safety compliance, and value-based care initiatives. We will touch base on this on this slowly in our upcoming slides. But however, the scope of CDI has been expanded just beyond the reimbursement. Now CDI helps in quality reporting. It also plays a very, very important role in the risk adjustment. I believe majority of the people, there might be many people who would be coming from a risk adjustment coding background. And it also helps in patient safety, compliance, and also in the value-based care initiatives. So now let's get deep dive into what is the purpose and the focus of CDI. So one, accurate clinical representation. So it helps us, like the CDI process helps us to reflect the true severity scores and risk of mortality scores. Generally, these are the ones, and overall patient complexity. So it helps us to understand what is the patient's actual severity. Okay, what is the patient's, if there is let's say the patient has acute heart failure. Okay, so it gives, so with CDI intervening in providing, or with CDI intervening in making the documentation accurate, it also clearly represents, or it also provides us a proper SOA scores and ROM scores. So the true severity of illness and the risk of mortality. So people who work in inpatient settings, they would already know the terminologies of this. So when a patient gets admitted, depending upon the severity of the patient's condition, there would be some scores which is called as severity of illness. What is the severity of that particular illness that the patient is having? It depends upon the patient's condition that is being admitted. At the same time, what are the other comorbidities that exist for the patient? So that derives a severity of illness score. At the same time, risk of mortality. That means, just simple way of understanding this is like, if based on the patient's current condition, if the patient left untreated, what is the risk of mortality? What is the chance of patient being alive versus dead? So for that also, there is a score of 1, 2, 3, 4. So when we have a proper CDI program in place, it helps us to capture these scores properly, especially in the inpatient settings. And of course, the next one is support accurate code assignment. The ICDs, the CMs, the PCS, the HCPCS, the HCCs, that actually drives the DRG or the APC assignment in the outpatient settings, and also the compliant revenue capture. It accurately captures, or it helps in not providing any high reimbursement or low reimbursement cases. It provides us accurate reimbursement cases. So quality and outcome reporting. Okay, so when the documentation is strengthened, the publicly reported metrics like mortality, the readmission tracking, the patient safety indicators, and the hacks. We call it as hacks, hospital acquired conditions. All these would be properly reported. And also, when the hospitals captures all these properly, it will impact their ratings. So we generally call them as CMS star ratings. Uh, so it is not just about providing the care to the patient. The hospitals should also have themselves listed in these CMS star ratings, like what is the quality of the care that they are providing. So when they start, when they, it's not, so again, as I said, like in the modern world, in the modern healthcare world, so hospitals are not just driving the patient care, they should also, they also started driving the outcome of the care and the quality of the care. So because of that, there are some standards which are set by CMS, and every year, so the CMS starts rating different hospitals. Like, so there is a hospital X and Y. The X hospital might have a 4-star rating, and just like how our hotels are, rated against the ambience, against the service that they provide. Similarly, the hospitals are also rated based upon the quality of the care that they provide. For them to have higher rating, so they should always report these mortality cases, the readmission cases, the patient safety indicators, the hacks, the hospital acquired conditions accurately back to the CMS or the government uh, or the federal agencies, wherever and whenever it is required. For them to report these properly, CDI is one of the major tools. So clinical documentation improvement is one of the major means and tools. So the risk adjustment and value-based care. So a proper CDI or proper CDI process also improves capture of chronic conditions and comorbidities. Again, that drives the Medicare Advantage, ACOs, the risk scores, and other value-based models. So we will get into deep dive about what is value-based model, what is value-based care, and etc. in our subsequent sites. But remember this thing in the risk adjustment arena, right? So proper capturing of chronic conditions is vital. So that drives the risk scores, which are which are managed by the Medicare Advantage plans, or Medicare Part 6. Okay. So compliance and audit preparedness. So this will mitigate risk of denials. So proper documentation, proper reporting of required metrics will help to mitigate risk of denials. Will also help to reduce the target from the RAC audits and also the payer disputes. So we don't need to go back and forth on appeals stating like this is the clinical significance, this is the clinical significance of this particular claim. So there is no need to explain these back and forth to a payer whenever there is a denial happens. And it also ensures that the documentation is aligned with official coding guidelines and regulations. Clinical communication and patient safety. This is also one of the major aspects of a proper CDI program or a process. So it provides a clear, complete, accurate patient story to support continuity of care across providers and settings. So it also reduces medical errors by eliminating vague or incomplete documentation. So remember one thing. So when a patient gets transferred from one hospital to another hospital or one provider to another provider, if the provider A doesn't properly document what the patient has, if the doctor A doesn't show the proper clinical picture of the patient, it will definitely affect how the doctor B is treating the patient, right? So the entire health ecosystem has to understand the significance of a proper documentation. So that is how that is where the CDI leads us. and provider engagement and education. So this also helps us. This CDI process or a program also helps to educate clinicians on best practices for the documentation. So there are certain traits, there are certain, like use cases of where the physician have some fatigue in documenting, in their documentation patterns. So with this CDI program or the CDI process, it helps to go back to the physician and say, no, so this documentation pattern doesn't yield us good. So you have to improve, or you have to specify this particular condition. You have to give us, it's not about just telling the patient has CKD, you also have to provide the stage of the CKD. So it helps to go back to the provider and educate them on the best practices, on the clinical terminology, and also the impact that creates on their notes. Because the documentation directly affects the reimbursement methodology or the reimbursement process on a claim. So even a small mistake, something that has not been documented by the physician, will lead to the revenue loss. So all these should go back. CDI, proper CDI program helps to go back to the provider and educate them and to make their documentation patterns better. So now, since again, as I said, like majority of us are from the coding background, CDI is currently evolving in the India market, and of course, in US it is already at higher position. So now we'll see like what is the major differences that we see in a CDI work versus a medical coding work. So this is more self-explanatory, but however, I just wanted to highlight like few aspects so that everyone would be aware of this. So the CDI goal is more to have the documentation clarity and so that everything in the clinical world is fully captured, which supports accurate reimbursement and quality reporting. However, in medical coding, it is more of the documented diagnosis and service are converted into standardized coding and billing for data. This ensures each documented condition is coded for claims and analytics. So these two departments usually go hand in hand. So there is a very thin line between. So the role specifics are clearly defined. Okay, so CDI is more work towards how to better or how to make the documentation better, and coders will apply the coding guidelines, coding knowledge that they have, the skills that they have, and convert the documentation. The documentation into reimbursable codes. So the timing. So generally, the CDI operates or starts operating when the patient's still in the hospital. So that is what we will generally call it as concurrent, especially in the inpatient stay. So the CDI starts their work, or CDI starts right in a concurrent way, which is like during the inpatient stay itself. However, in coding, we usually code after the patient gets discharged, right? So which is called as a retrospective based coding. Especially in the outpatient setting, CDA also works in a retrospective way because of, like, in a day, in an outpatient setting, a patient might see, a physician might see like 20 to 25 patients, right? So there will not be scope for CDI to work when the patient is still in hospital. So especially in the outpatient settings, CDI will, they'll work retrospectively, while in coding, especially majority of our 99% of the cases, we code in a retrospective way. So once the patient gets discharged or completes the visit. So coders typically code after service are ended and the documentation is finalized, while the CDI often work concurrently in inpatient stays and retrospectively in the outpatient stays. And they can, so with this, what happens is they can generate real-time queries. They can question the physicians if there is any problem in the documentation, or education can be given before the final coding happens. The focus of CDI is more of ensuring the provider's note clearly states all relevant diagnosis, complication, and the treatments are documented. So while in coding, so we usually ensures that every documented diagnosis or procedure have a proper code basis the official coding guidelines. So for the staff perspective, so the CDI specialist, so usually who are paramedics, alternate medicines, or clinicians trained, so who holds like CDI credentials. So these are the people who usually work in this area. And coming to the coding, as we all know, so we like people who work from or comes from RHIT, RHA, or healthcare related domains backgrounds, who hold certifications from AHIMA and AAPC. So the impact that these departments create, so the CDI leads to more accurate patient records, high case mix indexes, and few misdiagnoses. So it reduces denial audit risk by capturing all billable conditions and meeting documentation compliance, while coding, it generates compliant claims for reimbursement. So once, and it provides data for quality metrics and research. Also, accurate coding depends on underlying documentation that is created and improved by CDI. Simply to say, CDI is an upstream process and the coding is a downstream process in the healthcare reimbursement workflow. Okay, since we went into few slides, am I clear? Is everyone okay understanding this?
Yes, Harish, they are clear. Yeah, they are responding.
Okay. Okay, great. So now let's get into the world. I mean, let's get into this model called value-based care models or value-based care. Again, as I said, like in healthcare, there are so many recent developments, evolutions happening. Slowly, we are switching. Okay, whether you know or not, we are switching or we are slowly going towards this value-based care. So all the providers, all the payers are slowly converting their aim to get into a model called value-based care. Okay. So this value-based care. So what we see, I mean, what is the meaning of this? And we'll go with some examples as well for us to clearly understand. We'll see value-based care is a healthcare payment model where accurate and complete coding of diagnosis, procedure, and risk factors ensures that providers are reimbursed based on the quality and the outcomes of the care rather than the number of services delivered. So value-based care is all about outcomes. It is not about how much effort that we have put in treating the patient, but it is all about whether the patient outcome is good or not, whether we have provided a quality of care or not. Almost all the providers, healthcare providers, or the payment models, the health insurance carriers are slowly switching. I mean, almost there is a big transformation already happened into this in this area. However, we should understand what this area means to us and how CDI or coding impacts this value-based care model. So VBC also focuses on delivering care that improves health outcomes, enhances patient experiences, and reduces overall recurring costs. In this model, basically providers are paid based on metrics like patient outcomes, preventive care, and satisfaction, not on the quantity of the services performed. It doesn't matter whether physician has ordered some 10 different tests, evaluation tests, or they have performed 4 or 5 different procedures. It all depends upon what is the outcome of that care, right? And then BBC also emphasizes keeping patients healthier over time through preventive care, care coordination, and also chronic disease management, not just the episodic treatment. It is not just, okay, patient comes to this episode, we treat and send. No, it all, like, if the patient has any, I mean, like in his care model, if the patient has any conditions that should be treated with some other specialist, so they generally in this model, so they coordinate with each other and try to treat the patient as one team. Okay, so you go to a you go to an you go to an internal medicine or a general physician, and the problem with your renal system, so the general physician refers you to the nephrologist. So it's not like, okay, the general physician work is done. So care coordination is something where the general physician and the nephrologist all work together and provide you the best experience, provide the patient the best experience, so that they travel together throughout the case and provide you the best optimum output. So this is what is expected in the VBC model. So not just, okay, so the patient comes today, I'll treat. If the patient comes tomorrow, I'll treat, otherwise I'll leave. No. And even in VBC, so the preventive care is very, very important. This also reduces care. So if the doctors are, or the physicians are providing a timely based preventive care to their patients, there are so many chronic conditions that can be reduced, that can be managed well. If that can be managed well, the overall cost burden on the healthcare plans or health insurance plans will be reduced. So VBC encourages the providers to take the preventive care steps as one of the major aspects of it. We'll go through the basic differences of what a fee for service model is versus what a VBC model. We still see many insurance payers follow the fee for service. We still have it. So here in this fee for service model, what happens is, like, the doctors and hospital gets paid for each test, each visit or procedure they do. The more they do, the more they get paid, regardless of whether the patient gets better. But in comparison, the VBC model, the value-based care model, what it says is payment is tied to quality and outcomes instead of volume. Okay, it doesn't depend upon how many people you treat, or for each patient, how much amount of effort you have put. It all depends upon what is the outcome of that case. So the provider gets incentivized if the patients stay healthier, if the patient needs fewer hospital visits, and also manage chronic diseases well. It's more like saying, okay, so we'll reward you for keeping patients well, not just for treating them when they are sick. It's not like, okay, if they're sick, then providers would treat it. The VBC model will reward you for keeping the patients well through some of the models which I said previously. So chronic disease management or preventive care implementation, and with all those models, with all those methods, they'll control this and they'll ensure that the patients are keeping well. So just a small analogy that I've kept below. So if you can see, fee for service is more like, if there is a car that got into repair, so you pay the repair cost. That's it. Again, after a few days, the car comes to the garage again. You again repair, you take the money. Again, after a few months, again the car comes in, you repair it again, and you get paid. So that is more fee for services. But value-based care is more like, it is paid not to repair the car, it is paid for keeping the car running smoothly all year. you can just assume like car as a patient, repair as a treatment. Okay, so that is the major differences between our traditional fee for service model versus the current VBC model that is being driven across the healthcare industry. Okay, so some examples that I just wanted to put across, like what is this value-based care, how CDI and accurate coding impact this value-based care. Okay, so the first example that I would be going to the diabetes and risk adjustment. Okay, so before I get into this example, I just want to throw a question to the audience here. Like, while you're coding diabetes, okay, like, what are the major aspects from the documentation perspective that you need? So according to you, like, what are the ideal pieces of information that a physician has to document, especially when you are capturing diabetes? Yeah, just take a minute if you, and jot down your responses in the chat box. And Madhuri, maybe you can help me.
Yeah, we are receiving responses, Harish. Like they are saying type of diabetes should be documented, complication should be documented, and which system it got affected, and the combination code, blood sugar level, medication, insulin use, patient's history, underlying conditions, management, HbA1c. If it is gestational, it should be documented. Lab values. Yeah. These are the responses we received.
Great.
Yeah. Overdose
Great.
or
Thank you.
insulin.
Thanks, guys, for Okay. Yeah. There might be many aspects, right? Like whether the patient is hypoglycemia, hyperglycemia, any other, whether the patient has anything like ketoacidosis, anything. So there are many aspects, but yes, majority of the responses are right, and you're absolutely right, guys. And those are the major aspects of a diabetes documentation should be. Okay, but let's see and see like how CDI works and what are the major impacts that it creates with this example. Okay, so on the left side, so let's see like without CDI. So what happens? So this is just a normal example. So patient has type 2 diabetes with chronic kidney disease stage 3. This is a very straightforward example. So provider only documents type 2 diabetes. Okay. So what happens now? So the risk score is low. So again, this I'm talking specifically from the risk adjustment perspective, which is outpatient coding perspective. So the risk score will be low, right? So in HCC world, we'll have something called risk scores, depending upon how many chronic conditions that the patient has. So each condition has a certain risk score. So now here in this case, since the patient only has type 2 diabetes, which has been documented by the physician, ignoring CKD stage 3, the risk score is obviously low. So the payment is based on a simpler diabetic patient. Okay. So now, with the help of CDI, what happens is, or with the help of CDI and coding, so CDI identifies that the patient also has CKD basis the clinical indicators and queries provider to confirm its presence and stage, and the provider documents the same. So now the coder assigns both E11.22 plus N18.3. The risk score increases. So the payment to the health plan is adjusted upward, reflecting the true complexity of the care. Here, obviously, the risk score would be higher. And it also ensures that the health plan has the payments adjusted upward and reflecting the true complexity of the care. This also ensures resources are available for managing sicker patient. So from the from the health plan perspective, because we are talking HCC here, from the health plan perspective, so with this patient, once the proper capturing of chronic conditions happen, so their risk score is adjusted, and the amount that they allocate for this patient will also change year on year from when the patient has one chronic condition versus now the diabetes versus plus CKD both. So the health plan allocates a bit higher amount for this patient, and this happened because the CDI intervened and clarified with the physician, like, does the patient also has CKD? If yes, please document the specific stage. Okay, so so this is just a picture, or this is a very basic example for us to understand so the impact or how a CDI works. And once once the CDI and coding performs, so what is the next impact? So how the health plans are affected, or how the SOA scores are improved, and etc. etc. That is how it will help us to understand. So the next one is readmission reduction. Okay, so this is from the perspective of inpatient settings. Okay, so let's see this example. A 68-year-old male admitted with shortness of breath. So provided again, this is a very, very basic example, guys, for us to understand what CDI does in the value-based care era. Provided documents CHF only. So coder assigns I50.9, heart failure unspecified. On discharge, patient readmits within 12 days for worsening symptoms. So what is the impact here? Okay, so what happens here, or what impact that will be happen here? So the risk adjustment sees the patient as a low severity heart failure case because there is no specificity documented, right? So the readmission counts heavily against hospital in CMS readmission reduction program. So generally CMS tracks all the hospitals readmission cases. So readmission is more like I think they have a value. I mean, they have a period of 60 to 90 days, or within 90 days. There is not sure exactly. I can come back, get back to you. But the CMS tracks, monitors a program called HRRP, so Hospital Readmission Reduction Program. So where any readmission cases happening in the hospital, those has to be reported back to the CMS, and that will be counted against the hospital's performance. Okay, the lower readmissions, it directly tells us that the hospital is doing something great, right? So readmission counts heavily against the hospital in the CMS readmission reduction program. And also there is a high risk of organization facing a financial penalty. So now what happens once the CDI comes into picture? So with CDI and coding, so CDI reviews chart. So the notes that there are some echo findings, and the physician progress notes also indicates a reduced ejection fraction, and also there is something called chronic baseline edema that has been documented. So with these three, or with these evidence, so now the query, the CDI queries the provider. So can you clarify the type and the acuity of the heart failure? So the physician responds like acute on chronic systolic heart failure. So now in comparison with heart failure unspecified, so now we have a more specific diagnosis, which is acute on chronic systolic heart failure. So now the coder assigns I50.23 acute on chronic systolic failure. So what is the impact that it creates now? One, there is an accurate reimbursement. Obviously, there is a higher reimbursement that happens in the second case. Now the hospital readmission rate also looks appropriate because the patient has already a high risk patient. That means even if the patient is readmitted, however, the patient's original condition is not just heart failure. The patient's original condition is acute or chronic systolic heart failure. That means this patient is a high-risk patient. This patient is classified as a high-risk patient. Even if the readmission happens, this still looks appropriate. The organization of the hospital will not be vulnerable here because the patient condition is a high-risk condition. It also prevents unfair CMS penalty under the VBC program. Okay, I hope these two examples have given you some insights about, what happens without CDI, what is the significance of having a proper, clear, concise documentation, what impacts it creates, not just for the reimbursement, but the other programs, be it risk adjustment scores, be it hospital readmission rate reduction, or avoiding any CMS penalties, and etc. etc. So why do we require accurate documentation? Okay, of course, it gives us a clear clinical picture of the patient. It reflects the true patient risk and severity, right? So that means we will be able to accurately capture SOA, ROMs, risk adjustments, and the quality measure reporting. It also improves reimbursement and reduce denials. That means it supports correct DRG or the HCC assignment, ensure compliance, and prevents costly payer denials. The accurate documentation, obviously, the accurate reimbursement it reflects. Enhances patient care and communication. So when there is a clear documentation and improves care continuity, this is what I was saying. So if there are multiple physicians or multiple hospitals involved in the patient care, clear documentation will help improve the care continuity. It also supports proper clinical decision making and also ensures the future providers understands the patient history better. So every provider, it is not just provider A or B, every provider has to clearly represents the patient's clinical picture accurately through the documentation. So then only the patient's continuity of the care or patient's future admissions, everything will help properly for the physician to arrive at a proper clinical decision making. All these are related. Okay, so now we'll get into something called what are the top 5 documentation. This is an industry standard top 5 documentation issues that we found or that we find across the inpatient and the outpatient documentation, both together. But before I get into discussing about what are the documentation issues, since you guys are majority of your coders, often what type of documentation issues that you guys find? Yeah, you can note down your pointers into the chat box, please, and we'll see like whether these top 5 and your issues that you're observing in your documentation patterns are matching, or are there anything new that we wanted to learn here. Start jotting down your responses.
People are very interesting. They are listening to the session, Harish. We are receiving the responses very quickly, and the responses are incomplete MR, lack of specificity, documentation standards, SOIP formats, etiology, specificity, some
Okay.
credentials missing. And
Okay. Great.
Missing lab reports, incomplete documentation, no proper meet, missing proper documentation,
Okay.
copy paste formats,
Very good. Yeah.
signatures missing attestations. Yeah, maximum we covered everything, Harish. We are receiving repeated responses.
Okay, great. Thanks, guys. And yes, I mean, all of these are issues. I'm sure you must be facing these when you're trying to find or trying to capture a particular diagnosis or a procedure. You might have something which is not documented properly, some linkage is missing by the physician to give a combination code, or so and so. So yes, whatever the responses that we have received, they are true. And yes, we often face these issues when we are coding. Yeah. So let's see, like, what are the industry-wide, like, top 5 documentation issues that usually face, where CDI dwells and starts digging and try to make the documentation better. So insufficient clinical indicators to support documented diagnosis. Okay. Some of the examples. Okay, so ARF, acute respiratory failure, has been documented, but there are no proper ABG values. Oxygen requirements will be normal, or there are no stress distress indicators. Severe malnutrition is documented. So this is more inpatient focused, guys. This topic or this point on the clinical indicators. So be aware of that. So severe malnutrition is documented, but there is no BMI that has been documented. Albumin levels are normal. There is no proper documentation around weight loss, or there is no dietitian assessments that is available in the record. Of course, this is an issue. This is a very, very big issue. So in these cases, what happens is we will end up giving an unspecified code, right? Or we will end up not capturing that particular diagnosis, which will directly impact the reimbursement to the hospital. So this is something that has to be avoided. Again, the clinical documentation improvement process targets and mainly focus on these areas. So the next one is conflicting documentation between providers. Yes, right. Especially in inpatient settings, you guys will often experience this. The consultation note says one thing, and the attending says another thing, right? So the nursing assessment describes well-nourished patient, while physician documents severe malnutrition. So there is a clear conflict about, in one area it is being documented as the patient is good, while in the other area the physician says there is a patient has severe malnutrition. So this is a clear conflict, and there should be a clarity that we require for us to assign a proper diagnosis here. So this is called as a conflicting documentation between providers. So the next one is missing or incomplete POA status documentations, or present on admission documentation. Okay, so post-procedural complication lacking PO. So especially when there is a post-procedure complication. Okay, so there is a or especially I mean there is a complication that is being treated by the patient, by the physician. So there is sometimes there would be no clarity given by whether this complication has arisen because of the surgery that has been performed just before this. So this determines whether that particular complication is something which is present on admission or not, etc., etc. So this is very critical for inpatient settings because so there is this HAC penalties, like hospital acquired condition penalties, and quality reporting requirements. These are very, very important. So if there is any condition which is arised during the hospital stay, okay, so whether it is a pressure ulcer that has been developed, or the patient is very sick, sick, and the patient had a fall and had an injury during the hospital stay, or a fracture during the hospital stay. So these conditions are something which has come, or which has been acquired after the admission into the hospital. Patient doesn't came with these conditions. So in these cases, what happens is these are called as hospital acquired conditions. And when we start reporting this through POA indicators in the inpatient settings as no, these will be recorded against that particular patient's, so particular hospital's performance too. Okay, so that is the reason why we always require a proper clarity around it. Insufficient documentation to support E&M level and medical decision making. So medication, for example, like medication has been prescribed without corresponding diagnosis documentation. And again, I think some of the people have already told in the chat box, like, okay, copy paste documentation issues that don't reflect current encounter specificity. We often see this happening, especially in the outpatient settings. Of course, even in the inpatient settings too. But yeah, it happens everywhere. But yes, the copy and paste documentation issues are very high. Lack of specificity for default or unspecified code assignment. Okay, sepsis is documented without organism identification, which will defaults to A41.9. And 72% of the claims having sepsis, the claims having sepsis, 72% of the times gets reported as an unspecified sepsis only. And this is because there is no proper organism identification or a linkage. And one other basic example is like chronic kidney disease without stage documentation. Okay, so these are the top 5 areas where we generally see there are issues around the documentation. And apart from this, I also wanted to highlight the etiology. So physicians sometimes, like, they'll fail to provide the underlying condition for a particular diagnosis or the linkage, right? So sometimes when there is a linkage needed between, or the etiology or linkage needed between two conditions, they might not clearly state whether a condition A is because due to condition B. So this is also something which is very just like an example, like patient has encephalopathy due to UTI, patient has encephalopathy due to sepsis. So sometimes what happens is there is no clear clarity around whether what is the etiology of the condition being treated. So this linkage and the etiology documentation is also one of the major documentation issue, apart from these top 5 that we have discussed. And I'm sure you guys must have already experienced it in your real-time coding scenarios. And some of the facts, and these are very interesting. Okay, and so 92% of again, these are based upon some surveys that has been happened on the industry. So 92% of improper payments stem from the documentation issues only. When there is an improper payment that has happened, obviously 92% of the cases, it is because of a documentation issue. Maybe 8% of the issues patient doesn't have a proper benefits, like insurance related issues, patients plan related issues, or patients eligibility related issues. Maybe like 8% will get into, but 92% of improper payments happens because from the documentation only. In that, 59% is because of insufficient documentation, 19% because of incorrect coding. Again, this also because of it can be or cannot be because of the insufficient documentation, and 14% of it is because of no documentation. So as a coder or as a person who aspires to get into a CDI, we should strongly observe, we should be strongly aware how important the documentation is. 70% of the CDI professionals report sepsis as one of their top denied diagnoses due to documentation issues. Okay, this is a survey done by ACDIS, ACDIS, an organization. And what it says is, like, based on their survey, what they say is 70% of the CDI professionals says like sepsis is one of their top denied diagnoses due to documentation issues. Be aware of this. Yeah. And and in the same survey by ACDIS at this, so 74% of the respondents have identified respiratory failure as a top 5 denied diagnosis. So one is sepsis always takes the highest place, like most probably it will be in the top 1 misused or not properly reimbursed or highly error prone issues, error prone diagnosis that the CDI always observe. And respiratory failure will always be in the top 5. Okay, so majority of the CDI response stating like, okay, so respiratory failure will be in the top 5 denied diagnosis. Again, this is due to documentation issues. And also, there is one health system study found that 42% of the query responses resulted in MSDRG changes, leading to 9.8 million per month in additional. This is just, you take it as an average. Okay, so what this actually tells us is like, generally through their survey, so what they have found is that generally when the CDI needs a clarity, so they query to the physician, they ask clarity to the physician. So 42% of the cases of the responses actually yielded the higher reimbursement, which is averaging around $9.8 million per month. And you can just imagine like what is the impact of having the accurate documentation and how CDI drives that accurate documentation piece. This is some of the facts that I just want you guys to be aware of. On that note, let's get into some documentation checklist, right? So this is for CVA and cerebral hemorrhage. So again, from the CDI perspective, what all are important? So these are some of the checklist means like these are some of the aspects that a CDI will look into in the documentation, whether the physician has documented these pieces or not. If everything is documented, there is high chance that the documentation is accurate and the hospital receives or the physician receives a proper reimbursement. Okay, especially in the CVA and the cerebral hemorrhage cases, what all are important aspects? The time of symptom onset is important, right? The symptoms and the associated conditions are important. How long the symptoms lasted, because it is a CVA. In majority of the CVA cases, as you guys know, the hemiplegias, okay, and all those associated symptoms will not, or the right-sided weakness, left-sided weakness, everything. So generally they will not last longer. Okay, so they'll have an episode, and again they might come back to the normal state. So how long the symptoms lasted? So is there any history, including medical and family, relevant to this encounter? Type of the stroke. What is the CVA? So is it a thrombosis? Is it an embolism? Or is it other occlusion or stenosis? So or is it hemorrhagic in nature? Okay, so which includes the hemorrhagic infarct, laterality, and the cause of the hemorrhage. Is it because of an aneurysm? Is it because of a conversion, treatment, etc., etc.? So all these, so the CDI looks, I mean, a CDI professional looks for all these information into the chart. Is there any neurologic consult happened? And if that happens, what is the neurologist telling in his documentation or her documentation? What are the procedures performed so far? Was there any CT performed? Was there any MRI done, any laboratory findings we have, any cardiovascular screening done, any swallow testing done. So these are the documentation pieces that the CDI will look into if there is a CVA or a cerebral hemorrhage. Again, the reason for taking this disease to present is like, just wanted to provide you some examples around documentation checklist, or how the CDI generally looks into the documentation. What are the important aspects that they look into? So I've taken this as one example, CV. The other one is atelectasis. Okay, this is also one of the common misused, misunderstood condition, especially in the inpatient setting. We'll see like the recent. So whenever there is an atelectasis being documented, these are the aspects which the CDI would look into. So recent procedures requiring general anesthesia. Is there any recent procedure happened which caused this? Complication that occurred during the is this a complication that occurred during procedure or after procedure? Or is there any significant symptoms along with this atelectasis? Like, is there a shortness of breath documented, dyspnea, respiratory failure, decreased breath sounds, chest pain, fever, etc., etc.? And is there any additional diagnostic or therapeutic workup done? Is there a chest X-ray done? Is a blood culture that has been taken? Is there a respiratory therapy that has happened? And is this atelectasis a reason for extended hospital stay? So these are the checklists, or these are the documentation aspects that a CDI would look into, CDI professional would look into when there is a condition documented by the physician called atelectasis. This is more OP oriented. Again, this is like a spinal injections. Whenever there is a spinal injection, so the CDI professional would usually look into conditions like why this is being given. Is this being given for a diagnostic purpose, or is this being given for a therapeutic purpose? What is the anatomical region? That means, what is the exact vertebrae that this spinal injection is being done? Is there anesthesia given? Is there any fluid drawn? If the fluid is drawn, what is that fluid? Is that sent for a pathological consideration? Any catheter inserted for a fluid removal or something? What is the pressure reading for that? What is the pressure reading from that fluid? Is there any contrast media used? Any fluoroscopic guidance utilized? Or is there any specific substance that is being injected? All these are very, very important aspects of the documentation that a CDI looks into, especially for the spinal injections. Okay. So the next aspect that we would be discussing is on the clinical validation. I mean, like in the CDI world, you often come across this term called clinical validation. Remember one thing, as a CDI professional or a coding professional, we generally never judge how a patient is being treated. That means we never judge a physician clinically. Okay. A clinical judgment should never happen from both of us, like whether it is a CDI CDI professional or a coding professional. Clinical validation means it is ensuring that the documentation conditions are supported by the totality of the health record. I think we have recently seen an example like patient has an acute respiratory failure. Okay, what is the respiratory rate? What is the partial pressure, PCO2 values, PO2 values? Those are clinical indicators. When an acute respiratory failure is being documented, then all the supporting clinical indicators, are they showing the proper clinical picture? If not, can we go back to the physician and clarify with them? So we'll not ask them, or we'll not tell them like, this is not the condition. Maybe this is the maybe the patient doesn't have acute respiratory failure. The patient might have a pneumonia. So can you confirm this? So the clinical judgment is never being done by a CDI professional or a coder. So that will be left to the physician. However, based upon the different evidences that we find in the documentation, we can always go back to the physician to check whether the physician might have not documented or whether the physician would have documented a more specific condition. So these type of checks can often be done. So clinical validation ensures that the documented conditions are supported by the totality of the health record. As ACDIS defines it, the goal of the clinical validation is ensuring the health record is not only coded accurately, but also accurately reflects the clinical scenario within the health record. There is always a thin line where clinical validation and coding intersects. What is the purpose of it? To determine whether the documented diagnoses are clinically supported by evidence within the medical record. Scope involves a review of case to see whether a patient truly possesses the conditions that were documented. Authority. So has the responsibility, so the CDI has the responsibility to query providers when documentation lacks supporting clinical evidence or contains contradictory findings. Skill requirements. Okay, so this requires, especially for clinical validation, that means in the CDI, it requires strong clinical understanding, pathophysiology knowledge, and advanced clinical judgment. Okay, so in the real world, so we'll get into something called clinical criterias. In the real world, in the real CDI workflows, so there are certain conditions with which the physician would take a call whether the patient has a particular condition or not, or whether the CDI can query a physician based on some clinical criteria. Okay, so not all the conditions might have this clinical criteria, but the top conditions will have these clinical criteria. Some of them you might have already seen, but just wanted to introduce you, like these are some of the commonly queried or commonly clarified conditions on which basis a CDI can be clarified, on which clinical criteria a CDI can clarify or get clarification from the physician. In sepsis, there is something called SOFA or QSOFA scores. Again, guys, we'll not get into deeper on this because this is more of an introduction. So if you want, you can get into more, you can research on yourself and get acclimatized with these terminologies. However, when we do a series of these CDI sessions, we will definitely get into more deep dive around these areas. When we are discussing these areas, we will go as deep as possible in the clinical areas or especially the clinical knowledge. So for this presentation, I'll keep it as is. However, in the future presentations or the series that we come across in the CDI from our chapter, we will definitely go deeper into this. For sepsis, there is a criteria called SOFA and QSOFA, and also there is a criteria called CIRS. With this, it will help us to identify the organ dysfunction scoring, and also it helps us whether there is a proper or whether a proper infection has been established and treated or not in the encounter. AKIs, basically, in order to determine AKIs, so there is a criteria called KDIGO, Kidney Disease Improving Global Outcomes criteria. So according to this criteria, what it tells is, like, if the patient has a creatinine increase of more than 0.3 mg per in 24 hours, or if it is 1.5x of baseline within 24 hours, so that means that indicates that the patient has AKI. So these type of clinical criteria would be there, and as a CDI, CDI professional, they should be aware of this. Okay, because majority of the times the physician identifies the patient conditions based on this. And sometimes when we are clarifying or querying back the physician, the CDI should be aware of these criteria. And in the KDIGO, criteria. So they also have a criteria about urine output. If the urine output is less than 50%, so then it also leads to AKS, something like that. Okay. For heart failure, the standard classification is NYHA classification, and they also follow AHA staging. The malnutrition, it is more of Aspen criteria, Academy of Nutrition and Dietitians, American Society for Parent and Enteral Nutrition. So in this criteria, basically what happens is, so what is the weight loss? Was there any inadequate take, loss of muscle fat or muscle or fat, fluid accumulation, reduced hand grip strength? These are something that are measured. If the patient has any of these criteria, then high likely it will be classified under malnutrition. For encephalopathies, there is something called West Haven criteria for hepatic encephalopathy, grades 1 to 4. And the people who lose unconscious or who becomes unconscious, they have something called Glasgow Coma Scale, GCS. It measures the level of consciousness, and it will be reported out. For respiratory failure, basically the clinical criteria is more of an ABG criteria, arterial blood gases criteria. So PaO2 levels, PaCO2 levels, these are called partial pressure oxygen levels or partial pressure carbon dioxide levels. And also the pH levels of the blood. And also whether the patient needs a mechanical ventilation or a high flow oxygen can also support the severity. Acute coronary syndrome, there is a standard universal definition of MI which everyone follows. Troponin elevation plus ischemic symptoms, ECG changes, or imaging evidence. These are some of the clinical criteria on the topmost diagnosis with which the CDI works with in the inpatient settings or the outpatient settings. I know these might be new for you. I mean, like all these criteria and all might be new, but when you start learning CDI, obviously you should be aware of these aspects. Now let's get into an area called physician queries. So again, as we are talking so much about documentation, what is the significance of accurate documentation? If the documentation is not proper, as a coder or as a CDI person, you can query the physician asking, can you clarify this? Can you clarify this? So this is a process or more of a communication tool used to clarify documentation in the health record. Okay, for documentation integrity, and also for us to accurately assign diagnosis, procedures, services, etc., etc. So the physician query process ensures the health record accurately reflects the patient true clinical status, right? And also it supports the accurate, appropriate code assignments. It also meets the regulatory compliance and reimbursement techniques. So again, physician queries itself is a very big area. Again, as I said, in this presentation, I just wanted to introduce on this, just have a glance and introduction of what physician queries are. So there is this AHIMA and ACDIS. So they jot down the industry standards query practices and policies, and they publish us these. They generally call it as practice briefs. Maybe you can see, you can research yourself and see ACDIS or AHIMA practice brief. So they generally structure out the policies about how the physician query should look like, whom the CDI individuals should query to, when they have to query, when not they have to query. All these would be listed in that particular practice brief I'm talking. Again, I'm not going deep into physician queries because physician queries itself will be a separate topic for us to discuss later. But here I just wanted you guys to, I wanted to get introduced about what are these physician queries if you are not aware of. Important aspects of physician query, we should know when to query and when not to query. If the documentation already has the information that you needed, you definitely don't query. If the documentation is not specific, if there is some pieces missing, if the linkage is not there, if the etiology is not mentioned, all these cases you would query. You should also know, like as a CDI professional, or a coding professional, we should also know whom to query. Attending physicians we can query, consultants can be queried, specialists can be queried, even the nurses, clinicians, and therapists all can be queried. So how to query? Whenever you are getting clarification through physician queries, the language should be clear and concise. We should include specific documentation. We'll see some examples in the next slides. We should include clear, specific documentation references. Should never be leading. So this is very, very important. When you're clarifying or when you're asking questions or when you want physicians to clarify a few documentation pieces, you should never lead them into asking like, okay, I feel based upon this, patient has pneumonia. Can you confirm this? No. So you should never lead a physician to certain conditions and ask them to select or ask them to clarify that. So this is a very, very important aspect of physician queries. So this should never be done. So, and also when we are querying, we should present some objective clinical indicators wherever it is applicable. This is an example of a compliant query. If you can see, there is a acute respiratory failure case, and it is mentioned on HNP and progress notes. Also, it is also mentioned in the progress notes. So HNP states like there is a underlying pneumonia, respiratory rate of 12, no accessory muscles usage, arterial blood gases are pH of 7.40, PCO2 of partial carbon dioxide pressure of 36, and partial oxygen pressure is 75 on room air. So what's happening here is, okay, patient has underlying pneumonia, respiratory rate of 12 is normal. So there is no accessory muscles usages also. Arterial blood gases, pH is in the range. Partial pressure of carbon dioxide. So generally the partial pressure of carbon dioxide is, the normal value is between 35 to 45. And the partial pressure of oxygen on the room air, generally the value is 75 to 100. So based on this, so what the CDI is thinking is like, okay, so there is an acute respiratory failure that is mentioned. But this case is more leaning towards pneumonia. I think the underlying condition is pneumonia, because even though acute respiratory failure is being mentioned, but the indicators are not suggesting a strong case towards it. Okay, so that is when, based upon the clinical indicators, can you clarify the status of respiratory function in this case? Is it ruled out? Is it confirmed? Or if you have any other clinical findings, please specify. So this is the query that is being sent to the physician. This is a compliant query. So we are putting the documentation references. We are putting everything that decides this diagnosis, and we are also asking and providing enough options to the provider to select. It is not like the CDI is asking like an open-ended or something like that to give more descriptive way. So majority of the queries that a CDI sends, or even in that case in the inpatient side, the coder sends, will have options to select so that there would be less burden to the physicians, and also it will be clear and concise. This is an example of a non-compliant query. So there is a 72-year-old male admitted with SOB, hypoxia, and chest X-ray shows bilateral infiltrates. Progress notes mentions pneumonia. Lab shows like WBC is more, SpO2 is 85% on room air. Patient is on IV antibiotics. With this case, let's say, so in this situation, so there is only mention of pneumonia. There is no other condition or no other infection mentioned. Now the physician, if the CDA queries in this way, based on the patient's count, hypoxia, bilateral infections, etc., and also IV antibiotics, it appears that the patient has sepsis due to pneumonia. Please document if you agree. This is the leading query. Physician never mentioned sepsis anywhere, right? So there is no document. This is most like, okay, so asking the physician like, I'm thinking this, I believe you also think like this. So document if you agree. So this is more of a leading in nature and non-compliant. Again, as I said, this is the query should give enough options to the providers to select. They have enough clinical options, possible clinical options, and also there should be an option called other, so that if the physician has to go out and select the options, they should have a clear clear understanding about what's happening there. So why CDI matters today? So almost 10.4, the market of around 10.44 billion according to the estimates by 2034, which is almost like near to 8% CAGR. That means this is a growing industry. So what the stats tells us is this is a growing industry. By 2034, the CDI market would be in and around 10.44 billions US dollars. CMS and OIG audits are generally raising at a rate of 15% year on year. So the audits happening from the CMS side and the OIG sides are keep on increasing, and the increasing rate is also very significant, like 15% year on year. Okay, so generally what's happens is like the highly prone areas, highly reimbursement issued areas, they will be audited by OIGs, and OIG stands for Officer Inspector of General. So I mean, they are the federal agency where they look at into this fraud happenings, any abuses that are happening, any pattern of, and they also work on complaints. Okay, so if there is any complaint received by a particular hospital where they are overbilling, overcoding, etc., so they get into these things and they'll investigate and they'll also audit these. So these audits actually are been increasing 15% year on year based on a survey happened in 2024. So 30 to 40% of US revenue exposed to risk adjustment accuracy and value-based contracts. So that is also one of the important aspects why CDI matters today. And also one denial. Okay, so one denial will lead to around $118 to $136 admin cost. So each denial is giving us so much of burden on healthcare costs, single denial. So that is the reason proper documentation will lead to proper reimbursements, lesser denials, right? So that is the reason why CDI matters. So these are some of the workflows around inpatient and outpatient cases or outpatient scenarios. For the inpatient especially, the admission, it all starts with admission and initial documentation. Okay, we already discussed CDI works on concurrent screening. That means when the patient is already in the hospital, CDI starts reviewing the documentation and tries to find out if there are any gaps. So then the CDI concurrent screening starts. If there is any query opportunities, query will be generated with a target of response to be received within 48 hours. They'll have a target of like the response to be received by the provider within 48 hours. And there would be interim coding checks for DRG movements. So final physician attestation and the discharge summary is prepared. Once the discharge summary is prepared, so this will be moved for the final coding and QA. And if there are any clarifications needed, it will be holded for the billing. And final audit preparations, like especially from the audit preps, finally what happens is, are there any HACs, PIs that have been captured? Okay, is there any clinical validation issues happening here? Is there any POE review required here? So these are something that will be done post all these happenings, I mean, as an audit preps. On the outpatient, as I said, the encounter time is less in the outpatient settings. So the workflow would definitely differ. So generally in the outpatient setting, just wanted to clarify this thing. The query generation or getting clarified from the physician would be there, but it is not as high as inpatient. But apart from query generation for the outpatient, the CDI focuses on provider education. Okay, it is not just the query generation. The major impact that the CDI creates on the outpatient is provider education. So they often have to tell about, educate about the documentation patterns, what significance or impact that it will create, etc., etc. So if you can see, especially in the HCC area, so in the pre-visit HCC gap list, so pre-chart review will be done by the CDI, and there would be some alerts that has to be made. I mean, there would be some point of care alerts. That means especially whether the problem list is properly updated in that visit, in that encounter, whether chronic conditions is having a proper specificity in that particular visit. Okay, so there is something called E&M MDM support prompts. Okay, so for an E&M MDM visit to be properly generated, whether all the supporting documentation prompts are being captured or not. Okay, post-visit retrospective review, right? So most of the times the review happens post-visit only because it is an outpatient encounter. From the audit perspective, the monthly RAF checks, HCC checks, any feedbacks is required, these will be taken care of. Some major important IP and OP dimensions, or what CDI focuses on. So CDI focuses in the inpatient, especially it is more of DRG weight and CC and MCC capture because reimbursement is fully dependent on them. On the outpatient settings, CDI focuses more on risk adjustment scores and HCC accuracies. And what is the typical ROA? So in inpatient settings, they'll target around like $4.9K per corrected claims when there is a DRG shift happens from low to high. And in the outpatient, the typical ROA that the industry standard looks like 8 to 12% of risk score upliftment. The key metrics in the inpatient settings for CDI is CMI, which is called as case mix index. We can discuss that later. And DNFB reduction and patient safety indicators. These are the common metrics for CDI in the inpatient. And in the outpatient, it is more of checking like RAF variance, E&M leveling, whether it is happening properly or not. There are some AI use cases as well in these inpatient and outpatient settings. There are certain software, even 3M is also into this automatic CDI alert. And there is this next gen CDI care. There is another software which provides real-time alerts when the documentation is being prepared. Okay, so in the inpatient setting, especially the AI can help in case prioritization and reviews and the validation. And the outpatient, it is more helps in the chronic condition gap closing. So these are the major drivers. These are the major dimensions where CDI works in inpatient versus an outpatient settings. Okay, again, CDI. So now we're getting into more tactical about identification of how CDI work. I mean, as a CDI person, what are the screening methods of charts? Which type of charts they review? Which types of how they review? What is the methodologies behind this? These are very deep that we need to understand. And so, for example, in some days they capture or they concentrate on high risk diagnosis like sepsis, respiratory failure, etc., etc. On some days, so they look at the CC/MCC potential, capture potential, and also cases where there is a potential of more than $5,000 impact, or is there any SOA, ROM gaps? Those type of charts they would start reviewing. Quality flags, like if there are any hospital acquired conditions or a patient safety indicators that has been identified. So those type of charts, they'll be prioritized. Are there any situations where there is a 30-day readmissions or a mortality cases that is happening in the hospital? Those charts will be prioritized. Is there any chart? Is there any patient where it exceeds geometric mean length of stay, which is called as, so for example, sepsis has a GM for a particular hospital, okay, for a particular hospital, the average length of stay for sepsis is like 4 days, just an example. Okay, if there is a particular case which is exceeding this geometric mean, which is average length of stay, if it is increasing, so those cases would be coming under CDI chart review. ICU cases, complex surgical cases will also be reviewed by CDI. So especially for complications and the fracture cases, it is very important to identify whether those conditions are present on admission or not, especially in the inpatient admission. So even those PAO clarification is one dimension where the CDI chart review happens. Okay, so these are some of the conditions which are highly visible or highly worked by the CDI professionals. We should be aware of this. Okay, so we should be fully aware clinically what happens, what are the clinical indicators of these. If you can see, all these are something which we regularly use. However, for a CDI to review these conditions on a regular basis as a top DRG affecting conditions, we should know in and out. Okay, what causes this? What are the possible treatments? What are the possible diagnostic evaluation methods, etc., etc. Everything should be known. So these are some of the primary diagnosis triggering CDI reviews. Okay, so there are some case mix index opportunities. So case mix index is nothing but it is the sum of, so in a hospital there are 50 people that are being treated. All those 50 people, what are the DRG weightages combined together at an average? Okay, so it's a very important aspect of measuring the hospital's performance. High case mix index reflects that the hospital is treating severe cases. Low CMI represents that the hospital is treating the basic cases. Simple. Basic complex and severe complex. So cases, so again, these are some of the CDI review triggers. Cases with potential to move from non-CC DRGs to CC DRGs, where there are documentation gaps, where there are principal diagnosis ambiguity, where there are DRG opportunities of more than 5,000 reimbursement difference. These are CMI based triggers, which the CDI reviews the charts. There will be some payer specific triggers also. So in case of Medicare Advantage, the focus would be more on HCC capture and risk adjustment. If it is a traditional Medicare, DRG optimization is priority. So those DRG optimized charts will be reviewed more. If it is Medicaid, the concentration would be more on quality measure documentation. If it is a commercial payer, it is more on value-based contract requirement related reviews will be done by the CDI. There would be some laboratory value triggers also. These are some of the example. I'll not read out everything, but these are some of the laboratory value triggers also. Whenever a patient has an elevated lactate of more than 2, that is a potential septic shock. So CDI will review this case. Okay. If there is an elevated troponin, it represents there is a cardiac event specification. CDI will high potentially review this case. Elevated white blood cell count of more than 12,000, it might lead to CIRS or infection criteria. CDI will review. It is a trigger to the CDI review. There are some medication admission triggers also whenever there is a vasopressors being given. Shock or severe sepsis indicator. That is a shock or severe. Whenever there is a mechanical ventilation being done. So there is high chances that it is a respiratory failure, high payment error prone condition. So that will be reviewed. So dialysis cases, blood transfusion cases, IV antibiotics, if given for more than 48 hours, that is also represents severe infection documentation. All these are CDI triggers. As a CDI person, you should be aware of, people who are aspiring to get into CDI, they should know all these triggers. there would be LOAs based triggers also. If the LOAs is more than 5 days for medical admission, or LOAs is 7 days for surgical admission, that should trigger. Again, these are the industry standard triggers. These triggers, depending upon your CDI program setup and all, those can be customized separately based on the hospital requirement. But however, these are the commonly used triggers. For time being, I'll quickly go through it. And there would be some service line specific criteria also, other triggers that can, so all the ICU admissions can be reviewed by the CDI. Okay. All the surgical cases can be reviewed in some areas. Emergency admissions, especially for principal diagnosis clarifications, CDI needs to review those cases. Observation stays for more than 48 hours, all those charts need to be reviewed. Again, as I said, these are some of the common ideas of chart reviews or common triggers of chart reviews. It also depends upon that particular individual CDI program, that particular hospital CDI program, rules and regulations and policies also. They might follow something refined from these, or some might not even follow these and they might follow the basic triggers. Okay. Very, very important, patient safety indicator triggers. Okay, so there are certain areas, if there are certain conditions or patient safety indicators are where, how to say this is like, in a particular claim in a chart, if the particular event happens, like for example, the patient died. Okay, so it will be tagged against an indicator called patient safety indicator. So patient got a complication, that will be tagged under a particular patient safety indicators number state. So again, with this, what happens is from a particular hospital, that this patient safety indicators would be continuously monitored and reported back to the federal agencies, CMS or anything. That will also represents the hospital's overall healthcare. Okay, so what type of healthy, how the patient is being treated by the hospital, and etc., etc. So that will also be determined by the patient safety indicators. You can see there is a PSI indicator for pulse pressure ulcer. This is mostly developed inside the hospital, as you know. Iatrogenic pneumothorax. This happens during a procedure. Post-operative respiratory failure, post-operative sepsis, accidental puncture or laceration. All these events will have a particular patient safety called as patient safety indicators with some numbers. Again, against each claim, this will also be reported back if this happens as an event inside the patient's hospital stay. Hospital acquired conditions. Some of the examples. Okay, CDI use these cases whenever there is a catheter associated urinary tract infection, surgical site infection, if there is a fall with injury. All these different scenarios that I'm talking about, this will help as a CDI triggers for proper review. Yeah. Now coming to the as a CDI professional, if I'm working as a CDI professional, as a different position in a particular hospital or for a company or etc., etc., what would be my top 5 KPIs? What I would look for, or from the hospital perspective, okay, what are the top 5? So in the coding world, so what would be the KPI that we would be having? So there would be something called chart per hour, right? CPH. Depending upon the specialty, we'll have like inpatient 2 charts, surgery 4 charts, etc., etc. So that is one KPI. So we'll also have for outpatient it is CPT accuracy to be 95%. Okay, diagnosis accuracy to be 95%. In the inpatient world, it is DRG rate of DRG accepted, DRG accuracy of 95%, or PCS or diagnosis, or a POA accuracy of 95%. So all these are KPIs, right? Right? Or all these are targets or KPIs, whatever key performance indicators. So in CDI world, these are the top 5 KPIs. Okay. So what is the query response rate? Once a query is sent, what is the response rate? The target should be ideally more than 90%. What is the CMI improvement from annual CMI? The case mix index that we discussed, right? It is the relative values of DRGs for the entire specialty or the entire hospital. Okay, it basically CMI would be like CMI values would be 0.2, 1.3 for hospital, 2.3. It is an average of all the DRG weightages that the hospital is treating. So even the CMI improvement is a metric that the hospital will look at annually, and the target is to have 3 to 5% improvement. Okay, so this year there is 1.5, the CMI value for a hospital. The next year they will target 1.6 or something like that. So chart review. So it is expected that the CDI reviews 10 to 12 to 20 day. 12 to 20 charts per day. Target would be usually between 15 to 18. Query agreement rate. The query agreement rate should be in between 75 to 80%. The target should be more than 80%. This means if 100 queries are being sent, the physician is agreeing at least 80 cases of it, agreeing to the CDI version, at least in the 80 queries. So that is called query agreement rate. Query response rate is if 100 queries are sent, we are making sure 90% of queries being answered by the physician. And also revenue impact per case. Again, as I said, CDI is not always reimbursement. They will improve the SOA scores, ROM scores, DRG shifts, especially in the APR world, etc., etc. So at an average, the impact will be like there are 10 cases that have been treated. The target is whether each case has a 400 or overall, is there an average improvement or average reimbursement improvement of $400 or more or more. So that is a revenue impact per case. These are very, very important if you're aspiring or wanted to learn CDI, get into CDI. So these are the top metrics that majority of the hospitals, majority of the companies would enforce into the associates. So you should be aware of these. Okay, CDI impact cases, quick examples. Patient has heart failure plus respiratory failure, and they have admitted with exacerbation, hypoxia, BiPAP and all. And when what is the documentation gap? So there is no mention of acute respiratory failure. So this seems like an acute respiratory failure but is not documented because patient has O2 sats dipped, patient has BiPAP support. So what happens is when the CDI does a concurrent query to clarify whether an acute respiratory symptom, acute respiratory failure is present. So provider documents ARF due to CHF exacerbation. So this is just to show what is the CDI impact on the reimbursement. So here in this case, the DRG shifts from 291 to 189. The 291 will yield $5,200 while the 189 yield $9,800. Okay, because respiratory failure is an MCC. So there is an impact of almost like $4,600. Here, what is happening? There is a DRG shift happening, and also appropriate SOA and ROM is also being captured because we are getting a clarification about an MCC, which is acute respiratory. Another scenario, sepsis versus CIRS. Patient admitted with fever, tachycardia, UTI, so and so, so and so. Clinical criteria support sepsis, but physician did not mention this. Okay, so provider documents UTI with SIRS, but there is no proper documentation that the patient is having sepsis. In this case, once the clarification is done and the provider documents sepsis due to UTI, there is a significant DRG shift from 698 to 871, which has an impact of around average $7,100. Here, sepsis accuracy is reimbursement is one impact that it is created, and it also gives us some quality reporting alignment. The next scenario, this is more of an outpatient scenario, 58-year-old patient with neuropathy symptoms only. But there is no mention of diabetes. Okay, so diabetes mellitus, but there is no confirmation of neuropathy. Okay, so potential diabetic complication is missing here because patient already has symptoms, but there is no documentation of neuropathy or anything by the physician. So when this is queried, and if it is confirmed by the physician, like patient also has neuropathy, we have a higher HCC. So this gets into a combination code, type 2 diabetes mellitus with diabetic neuropathy. With just diabetes, it will be HCC 18. With diabetes with complication, it will move, the RF score will be increased and it will move to HCC 19. With this, the risk score and the adjustment in the value-based contract will improve, and also you can see the impact. It will increase at least 0.213 score of 0.213, which roughly translates around $2,000 to $2,500 additional patient payment per patient per year in a risk-adjusted contracts. Because HCC is more on the HCC is more main target is to financial target by the plan. I mean, financial to calculate the financial impact for the plan for the next year. With proper reporting, the healthcare plan can properly allocate. In this case, for that particular patient, the health plan for the next year, they'll allocate $2,000 to $2,500 more for the patient's care. Finally, I think we are at the end. Like some of the myths and misconception about CDI. CDI is just about boosting revenue. We already addressed this. This is not patient care, record accuracy, quality outcome reporting, many things the CDI would help into. CDI only hurts doctors with more queries. It's not just about only queries. What it says is this is a myth. It in turn helps the doctors to make their documentation more clearer. So if there is more queries happening to a particular doctor or a physician, it means that the physician is not maintaining a proper documentation patterns. So it improves often their documentation patterns itself. CDI replaces providers or coders? No, it's not. It strengthens the process, not replaces anyone. CDI and CDI specialists coders and CDI specialists do the same job. Definitely not. There might be some overlap in some areas, especially in querying portions, but the goals and everything is completely different. The guidelines, the goals and everything would be different. CDI only matters to inpatient billing. It is a myth. CDI is slowly evolving. Almost 50%, based on the recent survey, I'm not sure to whom to quote, but there is a recent survey happened from the ACDIS, and what it was mentioned is the outpatient CDI adoption is near to 50%. In the inpatient, if it is around 90%, the outpatient, it is around 50%. So slowly in the outpatient world also, the CDI is getting evolved and will soon get there with the required percentage on adoption. So this is the common myths and misconceptions. I think with this, we have covered almost everything that we wanted to cover. So I think we have few more time. I think we have 5 minutes. So these are the things that I wanted to present. Again, the idea is we wanted to introduce this CDI as a learning, as different series. We don't want to cover everything in a single pattern. This presentation is more to introduce to the CDI world and what they do, what are the important aspects of it. In each aspect of it, we can dwell deep into our upcoming series of CDI that we do from our Hyderabad chapter. But today, this is what we wanted to present. So hope everyone had a wonderful learning session. So I'll leave it for questions now. For now, for the next rest of the time, we'll spend for some questions if you guys have anything. So yeah, you can start jotting down your questions and putting into your chat
Thank
boxes.
you.
Maybe
Thank you for the valuable session. Harish, am I audible?
yes, you are.
Okay, so we are receiving few questions. Okay, so the first question is how the AA will be replace the CDI coding in future.
It is already there. It is in process. I mean, not in process. It is already there. Okay. Um, um, Hospitals started adopting these AIs into their documentation patterns to identify real-time alerts. When the documentation is being prepared, then in there itself, it will throw some alerts. The AI throws alerts, and it will give suggestions like there might be a improvement here, there might be an improvement here, there is a scope of improvement like this. Okay, but however, again, as I said, adoption of AI, I think we already did a separate session on this in our chapter itself by one of our officers. So yes, AI will definitely come into, I mean, AI is already into CDI. There are certain softwares which have these algorithms engines where it will read the documentation patterns and all. But again, currently this is being used as an additional tool rather than completely replacing someone or anything. The adoption rate is high because of AI currently, and currently like it is being used as an assisted tool rather than a replacement. Yeah.
Thank you, Harish. And there is
This
one
answers
more
your question.
question, Harish. Yes, it helps. And there is one more query raised here. That is to get a specialist in CDI. Do we need to opt for CDI certification?
So, yes, so the answer could be yes. See, there are certain organizations like AHIMA and ACDIS which provides the CDI certification. The famous certification from AHIMA is CDIP, and ACDIS provides a certification called CCDS. Yes, these are the certifications. See, certification is something which uh, which would be, yes, to explore into certain areas, to get into eyes of certain companies. Yes, certification is important. However, my suggestion is like if you are starting or if you want to start something onto CDI, first learn the subject, first learn what it is. And so don't put your certification as your end goal. Okay. Put learning the subject, learning about CDI, researching papers, what impact it is creating, and all. If you're already a coder, it will be easy for you to understand the CDI principles and all. So learn CDI. Your goal should be learning CDI, and the certification should be result out of it. So don't. My suggestion is like don't put your end goal as certification. Of course, certification in your professional journey, certifications are important. I'm not denying it, but don't put your end goal to only goal is to take the certification, because you'll end up only preparing for that. You'll end up only making your goals to clear those certifications rather than learning something new. So my suggestion is like, yes, I already told you like AHIMA, ACDIS organizations which provide the certification, and also about what you have to know. I hope this helps.
Yes, Harish, I agree with you. So completing certification is important rather than learning the concept is more important. If they learn the concept, they can easily clear the certification. Agree with you. And Harish, these questions are not related to CDI topics, but we do have few questions on the AA thing. Like, is AA taking over medical coding in future, or all medical coder jobs affected due to this AI, like HCC, ENM, IPDRG or something. Would you like to add any inputs here?
This is a common question that we would be getting. I mean, I think we address this separate. I mean, in separate forums. Again, and this is a very hot topic. I understood AI into coding. Guys, AI is already into coding. Okay, it's not like AI will come and take coding to take over the coding. AI is already there into the coding. The CAC systems, the 3M CAC systems is something that has been developed in the AI logic zone. So AI is already there. Okay, so however, currently the AI exploration is all about how to use the AI to do our jobs better than how to, I mean, like currently we are not in a world, or we are not in a position or a situation where AI is replacing coders and all. But currently, whatever the help that AI can do for us to do the work better, so that is where the world is currently, or that is where the evolution is currently. Okay, so if you ask me, is there any complete 100% automation with AI? There might be some specialities and all which are straightforward. However, that shouldn't be a reason, or that shouldn't be for a reason to worry, because with AI creates new jobs also. Okay, so how to use AI and get better results is also something which requires a human intervention. So that is also something which you should be aware of. And my suggestion is, don't think too much about what happens and all. AI is everywhere. Okay, so not just in coding, AI is in web development, AI is in teaching, AI is in training, AI is in everywhere, right? So it is all about how do we adapt these tools and make ourselves better is something that we need to think about. Madhuri, anything else? Any other questions?
Harish, am I audible? Sorry, I was talking on mute.
Yeah, now you are.
Thank you, Harish. Thank you for your valuable insights. These are the questions we have. And as we are crossing the timeline, if there are any additional questions, I'll consolidate everything and I'll share it with you. We can share the answer through our LinkedIn channel. Okay.
Great.
Yeah, on behalf of AAPC Hyderabad local chapter and all our session attendees, I would like to extend our heartfelt gratitude to you for taking the time to be with us today. Your expertise, clarity, and delivery of the session, explaining the concepts of CDI, how it is impacting the outpatient, inpatient scenarios. This is truly appreciate, and the effort you have put. Appreciate your efforts, Harish. And as we conclude, we kindly request all the attendees, you go back and check your CEs after 1 week time. We will consider your details through the registration link. All the required details you have already entered in your registration link. You have received through our AAPC Hyderabad local chapter. Okay. So please stay tuned to our WhatsApp channel and LinkedIn page for updates on the upcoming sessions. Thank you one and all for your participation and continued support. Harish, do you have anything to add here?
Nothing. Thanks. Thanks, Madhuri. Thanks, guys, everyone. So the enthusiasm that you guys shown to learn a new area in a healthcare space is very commendable. And keep an eye on the chapter announcements. We, from the AAPC chapter officers, we would roll out certain sessions, especially on the CDI. So we will try to bring in more sessions with different individuals as well as the officers to make you aware of this new area and to explore in this new area. So we will do some series of sessions of these. In between, anyways, we will have our regular sessions on coding and other areas. So, but yeah, keep an eye on the chapter announcements, the follow-up sessions of these, and etc. etc. So be active and follow us in LinkedIn, WhatsApp, and everywhere, so that you will not miss any specific communications related to the Hyderabad chapter. Okay, hope you had a great learning session. That's all we have. We are signing off. Thanks for attending again. Have a great weekend, everyone.
Have a great weekend, guys. Thank you. Thanks for joining.
Okay.
Thank you, guys.